Hello friends, today we are going to discuss about Munchausen syndrome, also called as factitious disorder. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about this Munchausen syndrome, what are the signs and symptoms, how to diagnose, and what are the different types of presentation, and also finally, how to treat them. Munchausen syndrome is a psychiatric disorder in which sufferers intentionally fabricate physical or psychological symptoms in order to assume the role of a patient without any obvious gain, but only to gain attention, sympathy, or medical treatment with regard to that they are sick. Munchausen syndrome refers to your patients repeatedly requesting medical care for their factitious illness. The reason it is called as factitious, the reason mainly because the word factitious means they have created artificially or contrived symptoms. These symptoms either can be physical or psychological. Hence, it is called as factitious disorder. But however, the term Munchausen syndrome was first coined by Dr. Richard Alan John Asher in 1951. The name Munchausen, the coined by Richard, was basically he was explaining the Baron von Munchausen's the way he depicted his gallantry work, and various things. Here, the Baron Munchausen used to enthrall his audience with incredible and dramatic, false, impossible feats, often featuring himself as a protagonist. That means he used to tell lie. And because of this character, this Munchausen syndrome, the name was given to this illness. And this illness is also been known by various other synonyms such as factitious disorder imposed on self. There is one more illness also called as factitious disorder imposed on others. Polysurgical addiction, hospital addiction, hospital hopper syndrome, hospital hobo syndrome, thick chart syndrome, hospital toxicomania syndrome, frater hospitalis, mythomania, and Van Gogh syndrome. These are the various names have been given to this Munchausen syndrome. The reason being is these factitious symptoms do not only occur with psychiatry. It can be seen in dermatology, it can be seen in surgery, it can be seen in urology, gynecology, and various other branches. Since many doctors and clinicians have seen, they have given various names to this illness. The persons with Munchausen syndrome, commonly they arrive to the hospital with sudden, often dramatic presentation. Invariably, they will have history of multiple admission in recent past. They often refuse to allow procurement of records from the past hospital where they have been diagnosed to be having factitious disorder. They actively resist by raising confidentiality, or else they will say that hospital and doctor did not do the proper procedure with regard to his illness. Invariably, most of the patients come to emergency department. The reason being they would like to get immediate attention. Invariably, they are willing to subject themselves to various investigation, invasive therapeutic procedures, even for diagnostic procedures. They do not say no to any of the procedures. Most of them are intelligent. They are quite interested in various medical condition. They are well versed with various medical terminology, and they would have read on internet. And most of the physicians consider this Munchausen syndrome is a challenging disorder for the whole team and all to the hospital. Invariably, the patients not only exaggerate the mild symptoms into severe, they may mimic act out the medical symptoms, interfere with diagnostic investigations, or even directly they induce symptoms on their bodies. A patient with Munchausen syndrome may also have considerable psychological impact on the treating team. Invariably, the treating doctor, the nurses feel that they have been betrayed, they have been duped, and invariably, the whole treating team feels this patient has cheated them. And many a time, the treating team can become hostile towards these patients. Studies on Munchausen syndrome demonstrate that there is a heavy impact on unnecessary investigation, treatment, waste of valuable resources, and also the hospital admissions of these patients invariably causes not available, the bed resources may not be available for the patient who is requiring these resources. And many studies have said healthcare cost of an individual with factitious disorder is somewhere around $2 lakh only. Hence, the motivation for this is described as an obscure factitious disorder because you cannot find any the materialistic gain. Invariably, the gain is more of looking for sick role, asking for attention, and being a patient in the hospital. Now, let's look into the detailed aspects of what is the motivation behind this Munchausen syndrome. Individuals primarily will have that invariably impulses to look for attention, seek for attention, desire to assume that they are sick, underlying emotional distress, wants to be calling or crying for help for attention, and this is the mechanism of coping with their various stress. Many a time the patients have said that they feel adrenal rush by cheating these doctors and undergoing various surgical procedures. Invariably, they feel sense of control over this healthcare industry by deceiving various healthcare service provider. That means you will not find any materialistic needs such as money or else evading the court orders or police cannot be seen. These are basically psychological in nature. Hence, you need to understand the factitious disorder revolves around seeking for attention, need for validating their emotions, being in control, and one way of coping with various stress. Now, the question is when to suspect Munchausen syndrome. First and the foremost, if the patient presents dramatically with inconsistent medical history, the patient reports of symptoms, but on asking for clarification, they are unable to give minor details. Invariably, they start giving various other symptoms. You will find predictable relapse following improvement. The patients will have extensive knowledge of their illness, medical terminology, and they will have classical textbook description of symptoms. Appearance of new or additional symptoms following negative investigation, willingness or eagerness to subject themselves to multiple investigation and surgical procedure. Further, history of seeking treatment from multiple hospitals, doctors without any improvement. Invariably, the onset is adolescent or early adulthood. Majoritarily, it affects females. That is, many studies have said 3:1. That means for every 3 females affected, 1 male may be affected. Most of them are healthcare workers. Hospitalization for medical ward or maybe in the surgical ward can be seen. A history of multiple hospital admissions are well known. They are willing to undergo any invasive procedure, either it may be diagnostic or therapeutic. And these episodes are triggered by various stress and also emotional turmoil. Now let's understand this factitious disorder or Munchausen syndrome. This syndrome is a broad spectrum of presentation. What do you mean by broad spectrum? It may present as a milder variant of Munchausen syndrome where the patient exaggerates their symptoms. If a person has mild headache, he will report he's having a severe headache like migraine and it is difficult to tolerate. Their pain threshold may be very less, but however, the dramatic presentation, seeking for attention, crying, and running to the emergency department is well known. Another example is the children, before going to school, they may have abdominal pain or they may would like to go to the toilet. You may attribute to various reasons. It can be separation anxiety, it can be because of anxiety or OCD symptoms. But there is no gain. The psychological distress can be the reason. If you look at this clearly, there is the spectrum at one end, exaggeration of symptoms, and invariably in the middle, the factitious disorder, that is, fabrication or production of symptoms without any illness and without any obvious gain. On the other end, there is a malingering. That means the patient invariably has a materialistic gain, either to avoid punishment or else to gain something. It may be insurance or maybe financial benefit. Of course, theoretically, this definition of spectrum looks good, but in real case, most of the patient fluctuates between exaggeration of symptoms to factitious disorder, and rarely they may even have malingering symptoms also. Comorbidity is the rule in factitious disorder. 35 to 40% of Munchausen syndrome has one more medical illness or psychiatric illness. Invariably, the illness which you can think of is hysteria or dissociation. Here the patient produces symptoms, but he has complete indifference towards these symptoms, that is dissociation. Further, a person has real physical illness, but here he exaggerates symptoms. You may call it as abnormal illness behavior, which was introduced by Pulaski during 1960s. Further, somatoform disorder. Here the patient is not worried about having illness, but he is worried about multiple aches and pains. He wants to get rid of this pain. Invariably, they seek treatment on OPD basis. Further, hypochondriasis. The hypochondriasis is fear of having an illness. Factitious disorder, which is Munchausen syndrome. And finally, the malingering. This is the spectrum you can see in real world scenario. Now let's look into the diagnostic criteria for factitious disorder. As per DSM-5, there are 4 important criteria. Criteria A is the patient finds psychological and physical signs and symptoms or induction of lesion or disease or factitious disorder. The individual presents himself or herself to others as ill, impaired or injured. Fraudulent behavior is evident even in the absence of obvious external rewards. That means there is no materialistic gain. Finally, the individual's behavior no longer can be explained either by delirium or schizophrenia. Either it can be episodic or continuous in nature. If you look at the various symptoms, invariably the symptoms are dramatic in nature, extensive knowledge of medical, presence of symptoms only, the patient may present alone, eagerness to have medical tests and invasive procedure, refusal for psychiatric evaluation, forecasting negative outcome that nobody can help me, suddenly becoming ill, and whenever they are discharged, the relapse occurs within a day or two. Many a time, symptoms are not clear. The symptoms moves from one system to another. The patient may have cough. Suddenly may he start telling, have musculoskeletal pain in the leg. Or else he may start telling abdominal pain or headache. Predictable relapse is well known. As soon as you'd start discussing about the discharge, they will have relapse or worsening of symptoms. And you can see presence of multiple surgical scars over the body, appearance of new symptoms, invariably whenever you confront with negative tests, history of visiting many hospitals and doctors is well known. Now let's look into the various differential diagnoses of Munchausen syndrome. Various differential diagnoses. First and the foremost is malingering. In malingering, the symptoms production is intentional and the motivation is very clear. That is, external, invariably monetary, or avoidment of any punishment. If you look at the somatoform pain disorder, the symptoms are unintentional. The gain invariably a sick role. If you look at the factitious disorder, there is no external motive. The motive is only gaining attention from care providers. And finally, the symptoms can be intentionally produced. If you look at the other differential diagnosis, it can be conversion disorder, hypochondriasis, somatization, nosophobia, and factitious disorder. And the malingering is clearly distinguished from above of the symptoms in the form of the gain is external, motivation is external and conscious, production of symptom is very clear, and they would like to gain the benefit consciously by producing symptoms and also many a time avoiding punishment. That is about malingering. If you look at the conversion, somatization, hypochondriasis, the gain will be unconscious at the level of seeking attention. If you look at the need for procedures, factitious disorder would like to have procedures to be done. Similarly, conversion disorder, somatization would like procedures to be done. So, my dear friends, you need to learn to differentiate between factitious disorder and various somatoform disorders, hypochondriasis, and conversion disorder, and to differentiate from malingering. Now, let's differentiate between Munchausen syndrome versus malingering. As I earlier mentioned, malingering is more common in men, whereas Munchausen syndrome is common in females. Malingering is associated with substance use, antisocial personality disorder, presentation of symptoms are vague, there is a clear-cut benefit by being sick, and most of them are psychopaths or antisocial personality disorder. Whereas in factitious disorder, the symptoms are vague. Invariably, they are producing the symptoms to gain attention, seek sympathy from others. The comorbidity, borderline personality disorder, is well known, and they seek for invasive procedures, diagnostic procedures, so that they get sympathy from healthcare providers. Now let's understand the difference between Munchausen syndrome versus hypochondriasis. In Munchausen syndrome, as I mentioned, symptoms are fabricated and exaggerated, whereas in hypochondriasis, it is a fear of having an illness. In Munchausen syndrome, the patient's invariably preoccupied with attention, seeking attention, whereas in hypochondriasis, the patient has a fear of illness and preoccupation with having an illness. Invariably, Munchausen syndrome is need for attention, in hypochondriasis, need for investigation, diagnosing, and treating the disorder. Invariably, in Munchausen syndrome, the disability will be very minimal. Activities of daily living are not hampered. Invariably, it is episodic in nature. Most of the Munchausen syndrome do not proclaim their illness publicly. They will show this illness only with the loved one people and with the healthcare provider. On the other hand, hypochondriasis patients invariably have disability. They will be very distressed about the symptom. They do go from one doctor to another doctor. They collect literature. They do not believe in the investigation. The disability will be very severe, chronic in nature. They proclaim their symptoms to everyone and they seek second opinion, third opinion. And hypochondriasis is very clear, fear of having an illness. Now let's look into an important study with regard to phenomenology of factitious disorder. This is a study published in General Hospital Psychiatry in 2016. Gregory Yates and his colleagues did an important study, that is review, the title by Factitious Disorder, a systematic review of 455 cases in the professional literature. In this, they found that female overrepresented the male. That is 65% of them were female. Most of them were healthcare providers. That means patients were from the healthcare industry. Often they challenged the diagnosis. Many a time the diagnosis was not straightforward. But the question is, how to suspect the syndrome? Yates and his colleagues clearly said that if the patient has passed multiple admissions, seeking treatment from multiple physicians, surgeons, and many a time information provided by the patient looks like a straightforward diagnosis. If you dig deep into the clarification, the patient may not be able to give a clear symptom explanation. Many a time you find that it will be atypical by after seeing 2-3 times, invariably unsubstantiated presentation. Their symptoms may be very severe, but however the disability will be very minimal. You can find evidence of fabrication of symptoms and signs. Patients' behavior do not go hand in hand with the presentation of symptoms. On one hand, they will say they are having severe symptoms, but inside the ward, they are mingling with everyone, participating, enjoying the life. Many a time, if you investigate by doing various lab tests, you can find they are fabricating even the lab test. Many a time you will find that none of the treatment works. Most of the patient will say, I have become treatment resistant. Do the best you can. And if you are about to discharge them, there is a sudden relapse or worsening of symptoms. Even if you challenge by showing that they have a negative symptoms or negative lab results, suddenly the symptoms will worsen. Further, many of these patients read literature or internet and they prepare themselves by providing classical textbook explanation of their signs and symptoms. Many a time, the unexperienced physician fall for this. They will do various investigation. They do even start symptomatic treatment. But however, early diagnosis, knowing that they are having Munchausen syndrome, engaging them is very essential. Further, the symptoms of Munchausen syndrome can cut across through all medical field, surgical field. Hence, there is an urgent need to train the postgraduates with regard to factitious disorder. And further, study by Yates and his colleagues yielded that the symptoms can occur from various field. It can be from pulmonology, allergy, cardiology, endocrinology, ENT, gastroenterology, hematology, dermatology, ophthalmology, oncology, name them. Invariably, the patient may have symptoms across all these fields. That means, if you are a psychiatrist, you need to liaison with all these specialities whenever the patient reports symptoms from the respective specialities. If you know the presentation, that dramatic presentation to the emergency department, where the path of resistance is very least. If the patient comes with a chest pain, invariably in emergency department, they would like to admit, do thorough investigation, would like to do ECG, angiogram, or the patient may come with severe acute headache with confusion, acute abdomen, seizure at home or office. Such kind of presentation, invariably, the emergency physician would like to admit and observe them. Further, if you look at the presentation, they would have seen many healthcare providers. They have strange multiple symptoms, do not fall into one category, spend most of the time in the hospital. Symptoms never happens in the hospital, but whenever you want to discharge them, symptom worsens. They would have undergone many investigation and surgeries. Many a time, the blood samples mismatch, or else they would like to contaminate these lab results so that they can stay in the hospital for longer duration. What is the prevalence of this factitious disorder? The current data from Norwegian patients have clearly showed that in general population, the prevalence is very minimal. It is 0.0026%. If you look at the clinical population in the hospital, 1 year prevalence is hardly 1%. This number varies across various studies. The reason being is where the survey was done. Is it the general public? Is it in the hospital? Is it in the surgical department? Dermatological department? What is the definition of caseness? On these basis, the prevalence varies. Further, Munchausen syndrome is considered to be very rare. Less than 1% is the clinical presentation in the hospital. Nevertheless, it is very challenging to any physician or surgeons. The question remains, how do we define it? What is the spectrum of factitious disorder? And it is presents to various branches of medicine. Hence, it becomes very difficult to know the incidence and prevalence. Invariably, these symptoms worsens during stress period. It may be during exams, maybe natural disasters. In such a situation, the symptoms usually pops up. Now let's look into the comorbidity. Invariably, Munchausen syndrome does not come alone. 35 to 40% of the patient will have one more comorbid diagnosis. The commonest is depression. Second one is personality disorder, such as borderline personality disorder, ASPD, histrionic PD, narcissistic and mixed PD. Anxiety disorders, substance abuse, suicidal risk, and DSH is very well known. But however, we need to keep in mind the ethical issues surrounding factitious disorder. First and the foremost, medical ethics clearly says, do not do any harm. Here, by engaging the factitious disorder patient, you need to say, we are not going to treat you. We are not going to provide the treatment for your symptoms. Invariably, the patient may become angry and he may go to the other hospital. If you treat as per his needs, we are going to harm the patient. The patient may raise confidentiality. He may say, don't ask anybody, don't talk to my family members. In such a scenario, should I talk to the family members for the best interest of the patient? These ethical dilemma becomes very difficult. That means if you treat the symptoms, he may worsen. If you don't treat, he may go to the other hospital. Such a dilemma exists in Munchausen syndrome. Now the question is how to treat them. Unfortunately, there is almost no information with regard to systematic research with regard to RCTs, open label trial for factitious disorder. We do not have adequate literature with regard to course and outcome, and also the long-term prognosis of Munchausen syndrome. Munchausen syndrome, as the majority will leave the hospital if the doctor comes to know this patient is exaggerating or fabricating symptoms. They move from this hospital to another hospital telling that they are sick. They usually refuse to acknowledge that they have psychiatric problem. The reason being the fear of being disclosed that they are malingering the symptoms, or the people may say that he is faking, fear of abandonment by the family members and the healthcare providers, fear of losing a coping mechanism by getting admitted to the hospital, fear of loss of trust by the loved ones. All this will lead to poor engagement with the treatment team. Further, since they refuse to accept that these symptoms are psychological in nature, it is very difficult to bring them for treatment in psychiatric department. Hence, we need to liaison with all the departments where the patient goes with the factitious symptoms. Hence, it is best to treat them in a medical college than in a mental hospitals. But however, based on the availability, we need to consider treating them either in the medical college district hospitals, or maybe even in the mental hospital. One need to look for the comorbidity and treat them aggressively. Since there are no RCTs with regard to treatment, course and outcome, prognosis, we need to actively invest in research of Munchausen syndrome. The treatment should be tailored based upon the presentation, and case by case basis you need to plan the treatment. You need to do a detailed evaluation, look for comorbidity, do only the appropriate investigation, liaison with other medical and surgical specialty wherever the patient says with regard to respective systemic branches. You need to go for opinion. You need to educate the family members and the patient, make aware of this illness, and many a time family therapy and rarely individual therapy helps in Munchausen syndrome. This is the flowchart where you can see, once you know that there is a factitious disorder, treat the comorbid condition, coordinate with all other healthcare providers and other departments so that we can coordinate the care, avoid all unnecessary investigations and treatment. Consider non-punitive confrontation of the symptoms and signs with the patient, and tell them, yes, we can understand that they're going through a turmoil and they're seeking attention by maladaptive coping mechanism. Hence, you need to help them to understand there is a healthy way of coping skills that need to be inculcated. Hence, engage them in a treatment, ask them to come once a month to look for specific doctor. Don't allow them to go from one doctor to another doctor. Avoid making investigation. Involve the family members in treatment of Munchausen syndrome. To conclude, my dear friends, Munchausen syndrome is a psychiatric disorder where the person fakes or exaggerates physical or psychological symptoms to gain attention from the healthcare provider. Diagnosing this Munchausen syndrome can be challenging to the many physicians. Only the skilled doctors, forensic psychiatrists, will be able to pick the diagnosis of Munchausen syndrome. Invariably, they will have a deep-seated need for attention, need for care, need for sympathy from the healthcare provider. Early intervention and treatment can reduce the severity of symptoms and also misuse of resources in the community. As much as possible, avoid hospitalization of patients, especially with Munchausen syndrome. Once you have diagnosed, please engage them on OPD basis. Do not criticize them. Do not tell that they are malingering these symptoms. Please do respect them. Engage them so that the patient realizes the long-term goal is to stand on his leg and contribute to the community. At present, there are no studies to look into evidence-based treatment with regard to Munchausen syndrome. The treatment has to be tailored based upon the case-by-case presentation and availability of resource. Do not do psychotherapy for all of these patients. This psychotherapy can come in the way of healing from Munchausen syndrome. That means psychotherapy itself can become a way of seeking attention by the healthcare provider. But however, please engage this group of patients meaningfully so that they can contribute to the society. Thank you very much for your valuable time. Stay safe.